Am I audible now?
Yes, sir, you're audible, sir.
Okay, I'm ready when you guys
Yes,
want to get.
Can we start, sir? I think Director sir has also joined us.
Okay.
Sir, MS sir, all of them have joined, sir. So can we start?
Surely, please go ahead.
Yes, sir. Pavitra, you can start.
Yes, sir. A very good afternoon to all the dignitaries, faculty and staff gathered here, and students and participants of e-competition joining through the YouTube live for the webinar being conducted by Department of General Surgery on the occasion of Breast Cancer Awareness Month. I would like to invite Dr. Naresh Kumar, in charge HOD and Associate Professor, Department of General Surgery, to welcome the dignitaries and the guests.
Thank you, Dr. Pavitra. Namaskaram and good evening. It's my great pleasure to invite you all on this platform for the webinar on breast cancer awareness, as we are celebrating this month as Breast Cancer Awareness Month universally and also at AIIMS Mangalagiri. So at the outset, I would like to welcome our beloved President Sir, Professor Dr. T.S. Ravi Kumar on this platform, our respected Director Sir, Professor Dr. Mukesh Tripathi Sir for this webinar, our Deputy Director, Mr. Shramdeep Sinha, Dean Sir, Dr. Joy Ghoshal, Medical Superintendent Sir, Dr. Rakesh Kakkar, senior faculty members, colleagues, nursing staff, and dear students. Again, I extend my warm welcome to all of you on this platform and hope it is a memorable evening today. Thank you.
Thank you, sir, for the warm welcome. Now I invite our director. Sir has been the guiding force under whom we have conducted various programs in this month of breast cancer awareness. Sir has been the guiding force behind the Integrated Breast Wellness Clinic, which is soon to be established in our institute. I request Sir to deliver opening remarks for the event today.
Good evening, everyone. Respected President, Dr. T.S. Ravi Kumar, sir, and Department of Surgery, all the other persons who have joined, the faculty members, and all everyone on the webinar. There is a seesaw change, I will say, that last year when this event happened, we visited New Turkey with President sir, and we had a very nice interaction over there with the public health worker group. And now this year we are just restricted for the same event on a webinar. But nevertheless, things have to move on. And as we all know that the cancer is the issue which was in limelight when I was undergraduate and still continues challenge to the society, and lot of research and chemotherapies and variety of radiotherapy, all plus surgical, modified, from radical mastectomy to exenteration to conservative mastectomy, and all those procedures have evolved with due course of time. But delayed detection, I think delayed detection or delayed reporting by the patient still remains a challenge, because it is quite, it has become therapeutic or curable if detected early rather than late. So I think early diagnosis still remains a paradigm or the need of the hour, all to control the this particular malignancy. And I still remember that in my final year exam, my major case of surgery was CA breast. And at that point of time, when I was asked that if a same person comes with a backache, what will you do? And one of my senior tried to put a cross from his fingers, but I could not guess that he wanted that the radiotherapy should be the answer. So I excused at that point of time that I don't know, but I passed anyway. So probably that was not expected from me at that point of time. So malignant CA breast cases and all those have, plus in my pain practice, I have seen the patients of brachial plexus injury and elephantiasis after mastectomy, post mastectomy complication and pain, and then something like CRP like presentation of unilateral hand related problems. So even surgery, doing surgery sometimes leaves the patient miserable, and lot of complications do happen. So it is a surgical challenge as well as therapeutic challenge for all of us. And I congratulate the department that they have organized this webinar, and I welcome all participants for their, and I hope this contribution will enlighten everyone and to achieve our goals of controlling the malignancy in our setup. So I welcome everyone. Thank you very much.
Thank you, sir, for those insightful words. As you rightly said, early detection is the need of hour in management of breast cancer. Now, I humbly request our president, sir, who is surgical oncologist with wide and rich experiences across the globe, both as a renowned surgeon and an able administrator. He has initiated many screening programs for cancer across the institutes. I request sir to unveil the breast cancer pamphlet and address the gathering with his keynote address.
Greetings to all of you. And I appreciate the invitation from Dr. Naresh and the director to participate in this program and deliver the keynote address. Before I start the address, as you already announced, can we do the release of the pamphlet first or at the end of my address? How do you want to sequence this today?
We can start with your keynote address, then we can launch the event.
Very good. So anyway, greetings to all of you, the AIIMS Mangalagiri family and the larger family of oncology and health providers in the region, and hopefully there will be some participants from around India in this webinar. I would like to make about, during my 10 minutes or 15 minutes, 5 points. The first point I want to make is about the status of cancer care in India and globally. I will just link with GloboCan 218. If you don't want to show it in the slides, it's okay. I can talk to it. The second thing is from the overall cancer status of cancer in India and abroad. What is the status of breast cancer in India and what are the opportunities? Third point I would like to make is the paucity of population level data lacking in India because of lack of cancer registries that are population based, and my suggestions and solutions I've been trying for the last few years in India. The fourth part is just to recount my experience, how it will all come to play in terms of my being an advisor in this role, not only as a president, but as a catalyst for transforming breast cancer and cervix cancer in women towards women's health. And the last point already mentioned by you, both of you, is that how has the pandemic shaped the cancer care? There are a lot of studies in the world now, how next year we're going to see how 2020 will come out as a dismal year for cancer outcomes because of the crowding out of the cancer management, heart management, variety of other diseases, because we are focused on COVID, and we should not just shortchange the cancer care. So these are my 5 points. So let me take to the first point. If one looks at the most authentic data by WHO, World Health Organization, every so often, almost every year, WHO puts out now what's called Global Observatory on Cancer. It's called GloboCan, Global Cancer Observatory. And established data comes from 2018. The projected data of 2020 needs to be validated. The data from 2018, the recent GloboCan data, shows that, let me just compare India and US. So it gives you a stark difference, especially in breast cancer. New cancer cases in India in GloboCan is 1.16 million, okay? 11 lakhs 600,000, 60,000. So 1.16 million people are diagnosed each year from cancer, and annual cancer deaths is about 785,000. So 785,000 of 1.16 million gives us a death rate of 68%, which is alarmingly bad for a country like India. And compare this to the USA. USA is not doing well in the pandemic because of a lot of flaws, but USA has done remarkably well in some of the cancer care. And US, in the corresponding year, 2018, where there are 1.16 million cases diagnosed in India, USA, with about 1/4 of the population, has higher number of cancer diagnoses. In the new cases in USA in 2018 is 1.74 million, 1/3 more than a 4 times populous country like India. One can say this is due to the genetic basis, could be due to all the cultural changes and diet and habits and a cancer-prone population, but also it is because of accurate diagnosis and collecting the information. That's one point I would like to come back in the end. Among the 1.74 million cases diagnosed in the USA, which is much higher than 1.16 million cases in India, the death from cancer in USA, as against 785,000 in India, is only 609,000. So the death rate when India is 68%, while in USA it is reversed. In US, 2/3 of the cancers patients will die when you're looking at the death rate. In US, only 1/3, 35% death rate. Among the 1.74 million, the death is only 609,000. So if you want to link it to the cancer control strategy, which we now need to go robust in the coming years, very simply put, there are lots of aspects of cancer control. But very simply put, it's like two legs of the arm, two legs of the problem. One is prevention. You need to prevent to reduce the death rate from a particular cancer. There are preventable cancers and some cancers are not preventable. The strategy cannot be one hat fits all sizes. The second aspect that fits all sizes is called early diagnosis. Every cancer has to be diagnosed early. There are methods to do that, and most cancers, 80% of the cancers we know of, can be diagnosed early. And early diagnosis, what does it do? As I showed you the example in the USA, it causes there are terms called variety of terms. It migrates the stage. It moves the stage from being diagnosed in stage 3 and stage 4, and most patients are diagnosed in stage 1 and 2. So this stage migration improves the survival rate. The earlier diagnosed, the better the patient care is, and the better the survival. And also, it pays dividend in after 5 years in terms of the cost of cancer care. Because caring for a patient in stage 3 and stage 4, for example, we'll come to the breast cancer in a second, is 2 to 3 times or 4 times higher than the care of the cancer in stage 1 and 2 because of the modality of treatment involved. The palliative care is not necessary in those early stages, and more people are cured and be very productive, and the feedback and the payback in GDP is incredible in terms of early diagnosis. So that is the economic imperative. Along with this, high incidence, relatively lower incidence, but high death rate in India is one of the few countries where women are more affected from cancer than men. Among the 1.16 million cases diagnosed in India, 587,000 are women and 570,000 are men. Women are disproportionately more affected than men. And what are the drivers for this? Breast cancer, cervix cancer. And all the other cancers are common to both sexes, except for the prostate cancer in males. But the drivers, breast cancer and cervix cancer, puts women at higher risk than men in India. And these two are eminently preventable and curable when diagnosed early. So that is the huge imperative for me when I was in SWIMS, for example, to roll out the pink bus strategy. We may not need the pink bus in the coming year because of the pandemic, but we need to have the strategy of what we call the bundled screening. When we have, it is called opportunistic screening. When women come in or men come in for other diseases, you ask the correct questions and make sure what risk category they are for cancer development. And if it is preventable, and if they are able to be screened, we need to put them on the screening program. And it is called opportunistic screening. The second thing would be community-based screening. You go out in the community and look for all the things, get the cancer control, get the statistics, and do a targeted screening. That is community-based screening. So these two, even when you do the opportunistic screening, you need to do the bundle screening. So the pink bus strategy I evolved, when you go into the community, take the bus, take the cancer screening to the doorstep. That is the concept. If they can't come to your center, you need to take it to the community. We need to now evolve. And to my last point, I'm going to say evolve strategy in 2021, better than what we have done in the past, and use the opportunity of telemedicine and telehealth to get to the doorstep of the women and men in the community. The second point I mentioned is about the breast cancer. Among the 1.16 million cases I mentioned, 15% almost, 162,500 new breast cancer cases. In fact, in India, breast cancer is the highest, number one in the cancer in India. It's not lung cancer, it's not oral cancer. Now it has eclipsed all of them. Breast cancer is the number one diagnosis of cancer in India. So among the 162,500 women diagnosed with breast cancer each year, 87,100, more than 50%, 54% death rate for breast cancer in India. Again, compared to the US. In the US, as against our 162,500 new cancers, in the US, it's 30% more. 275,000 new cancers are diagnosed in the US each year. Even with 274 diagnoses, the death rate in the US from breast cancer is only 42,170 compared to 87,000. It is half of it is in India. So the death rate from breast cancer in USA is 15%. The death rate from breast cancer in India is 54%, 3 times or 4 times more. This is not acceptable. Why? Because we don't have a cancer control strategy. And second is late diagnosis. 2/3 of the breast cancer diagnosed in Western countries are in stage 1 or in early stage 2. And in those patients, 90 to 95% are cured. Not 5-year survival, they are cured in stage 1 and stage 2A. In India, 2/3 of the breast cancer are in stage 3B or stage 4, when only 1/3 is cured and less than 1/3. So it's a flip coin. 2/3 are cured when you have early diagnosis. 2/3 die when you have late diagnosis. When I was in JIPMER, when I was in SWIMS, the commonest stage cancer is stage 3B or stage 4, not stage 1 and 2. So this is the status of the breast cancer in India. Let's come to the Andhra Pradesh, where we are among the 13 districts. And in SWIMS, I put in a Rayalaseema cancer program. I'm sure because of the pandemic, it was stalled. In Andhra now, based on May 2020 statistics, there are 54 million population. In the central Andhra, if you look at Prakasham district, Krishna district, Guntur district, and West Godavari, it's about 18 to 19 million population, less than 20 million. In that 20 million population, if you consider this is 1.5% of the Indian population, and if we consider the cancer rates of India translate into central Andhra Pradesh, it's about 2,500 cancer cases per year. So in our catchment area, in our area where we are as a regional leader, if we establish a cancer program, we need to be able at least to diagnose 2,500 cancer patients. And over the year after year, we need to migrate the stage of diagnosis from stage 3 and stage 4 towards stage 1 and 2. That should be our goal. The next is how we can bring the incidence down from 2,500 cases per year. Maybe it will be larger than 2,500 because we're not detecting all the cancers in the community. They may be dying of other things, still may have breast cancer. So there may be about 4,000 cases, there may be 3,000 cases. So we need to have a strategy. This should be the framework in which we have to work. The third point I want to make is the population level data. When you go to GloboCan 2018, and the GloboCan 2018 cancer data in India is culled from 26 cancer registries in India. And many of the cancer registries are referral registries, not population registries. They come to you, you get in the cancer center, or the government sets up a program, and you accrue all the cases, and we don't even know how many in the community. So we don't have there are some population level registries in India, but we look at the 26 registries from which WHO culls the data and normalizes to the population. Andhra Pradesh is not represented. You can go back to the GloboCan, maybe I missed Andhra Pradesh. They look at 26 registries, they say they collected the information, and Andhra Pradesh is not represented. That's what I took it on in 2018 itself, take it to the state government and say we need to establish a state cancer registry. And then, since it will be difficult to establish a statewide cancer registry for all 13 states, the proposal we should be considering is the Rayalaseema, the 4 or 5 districts, be one cancer registry. I call that Rayalacan. And the central Andhra Pradesh, the 4, or if you want to include East Godavari, 5 districts of 20 million, you call it a central Andhra cancer registry. And then Srikakulam and other eastern districts, 3 or 4 districts, you can call it a, base it on Vizag, for example. You can have a registry. This is my pie in the sky wish. And so towards doing this, AIIMS Mangalagiri, as you rightly said, should launch a cancer program, a cancer center. Like in any AIIMS, we should start evolving now a comprehensive cancer center. And within that comprehensive cancer center, we need to have a comprehensive breast wellness program. And within that cancer center, we should have a cancer registry. We can start with the referral registry and then track the patients, but then link ourselves up to the state government, to the community cancer centers, to the primary health center. We need to have a population-based cancer registry. This should be our overall paradigm. With the evolution, with the pandemic, we will have a challenge. And most cancer patients, they don't get the care, even in Western countries. And in the Tata Memorial has published some of their information in Lancet. You can refer to that in some of what strategy they want to do. For India, people do not get a cancer care in early stages, do not get all the treatments, and they may die of cancer who could be potentially be cured. And our screening programs have gotten a short shrift. So that we have to change. We also have to change all the insurance program, even the public financing, PMJ, for example, Jan Arogya Yojana. And they pay for the diagnostic mammogram. They are not yet paying as of 2 years ago. I'm talking about, I'm not sure what is in 2020. All the screening mammograms have not been paid for. So that is the imperative for me to get the donations from Rotary, from donors, to establish screening mammogram free of cost to the public, not covered by public financing or a private financing system. So we need to make sure the mammograms are paid for, not only the diagnostic mammogram, but the screening mammogram as well. As of now, I'm not sure they may be saying it on paper, but it's not being paid for in real time. So that we have to change, policy change. And lastly, how can I be of help? When I came to USA in 1976, during 1970 to 1980, this is my last point. I was a resident in Brooklyn, one of the poor socioeconomic borough in the USA, and one of the most densely populated 5 boroughs of Manhattan, Brooklyn, Bronx, Queens, and Staten Island. And I was a resident there. At that time, they rolled out a project. One of the first projects of its kind is called BCDDP, Breast Cancer Detection and Demonstration Project. A lot of the studies that are now coming out has their roots to the BCDDP done in Brooklyn. My program director and chairman, Dr. George Degenshine, was interested in breast cancer. I was put in the group because I was interested in surgical oncology to screen all the women. So I had firsthand experience of participating in BCDDP as a surgical resident during that 4 years plus the 2 years as a fellow. And as a result of that, my breast cancer interests have perpetuated throughout my career. When I went to Yale University in my second faculty position, I was made the director of Yale Breast Care Center, Yale Comprehensive Breast Care Center, YCBCC. We don't call it a breast cancer center, we call it breast care because we want to be able to see adolescent women and young women, breast health, prevention mode, not just breast cancer only. So that was inaugurated by then Vice President's wife, Marilyn Quayle. Dan Quayle was the Vice President. I invited Marilyn Quayle to be the opening inauguration. She had breast cancer. She became a spokesperson for breast cancer, and she inaugurated my YCBCC. And since then, I went to develop a cancer center in New Jersey. And last program before I came to India was at Geisinger Health Center in Pennsylvania. Geisinger Health Center has the most robust rural health program. I was a cancer center director at Geisinger. We got an NCI designation as a NCI Community Cancer Center program. I was the program director. There again, we established a breast cancer program, went into the community. We had a survivorship. We had a palliative care program. Important thing when you develop this breast center is the breast center should be open all days of the week. Can be staffing it in a different way. But all breast cancer patient, I know from my own experience, it's best it should be one-stop shopping. You don't want the women to come for a diagnosis and go back and come to see the surgical oncologist, and go back and come and see the radiation oncologist, go back and come and see the medical oncologist, and if the person wants a reconstruction, come back and see the plastic surgeon. So when you design a cancer program, this site-specific cancer program, we had, for example, the last thing we had it on Wednesday. Wednesday, all people interested in breast cancer will be seeing patients under one roof. And the patient will sit in the room. The consultants will go around and see the patient. We schedule it in such a way, it'll be a part, breast cancer part. We have 3-4 rooms for each of the surgical, medical, radiation oncologists, palliative care, clinical trials program, imaging program. And the patient will come and say, okay, you're now having this present, it's not a cancer, you don't need to come. You can, if you want a reconstruction or you want a prophylactic mastectomy, you'll see a plastic surgeon and go home. Or if you have a stage 2, stage 3 breast cancer, where multidisciplinary management are needed, whoever is being scheduled to see the patient, depending on the stage of the cancer, they will be seen by other oncologists. And either in the middle of the day or the end of the day, you have a tumor board. Everybody will discuss the patient seen on the same day and then give a preliminary report to the patient before she goes home. Or we'll say, we'll call you with a multidisciplinary input the same day and then design a treatment plan. That's how the breast center should work. Not just to have a breast center physically and then patient will come and go multiple visits. So it should be frugal, it should be patient-centered, and it should be efficient and effective. So this is my advice and suggestions on this Breast Cancer Awareness Month. And we can evolve some strategies in the post-pandemic or intra-pandemic era. The pandemic is not going to go away tomorrow. And 2021 may still be within the pandemic. And I would like to be involved in designing new paradigms using telehealth technologies and taking it to the community and to the women's doorstep. Make sure that every woman in 5 years from now will be diagnosed in stage 1 and stage 2 breast cancer. And we will show that from 2,500 new cancer cases in 2018, we now brought it down to 1,500 new cancer cases in 2025. And in 2025, 2/3 of the breast cancers in the central Andhra Pradesh are diagnosed in stage 1 or 2. And hence, the following 5 years, the survival from breast cancer will be similar to the Western evolved countries as against the 2/3 dying from breast cancer in India. So I thank you for this opportunity. And this is the framing of the issue that we need to think about. I love to participate and put my 10 cents worth into this equation. Now, congratulations, Dr. Naresh Kumar and Director and all the people in the AIMS family to take the lead on this breast cancer and breast center, breast wellness program for Central Andhra.
Thank you, sir.
Namaste.
Thank you, sir, for the very informative talk about the current scenarios, the lacunae in the breast cancer care, and the future measures that can be adopted by us to overcome them. Now I request you to unveil the pamphlet on breast cancer awareness, sir.
I'll be pleased to do so virtually.
Yes, yes. So you just have to click that, sir. Link.
You have to click it for me. Where is the link for me? Okay, go ahead.
Yes, sir.
I'll share it, sir.
So
Yeah,
we will
let's-
share it from here, sir.
Yeah, I clicked it already. You can click on my behalf.
Yes, sir. Yes.
Yes.
Thank you, sir.
Very nice. Thank you. I'm applauding. You can hear my applause?
Thank you, sir.
Yes, sir.
Very good, very informative. Bilingual, or are you going to make it trilingual?
Bilingual, sir.
Bilingual, sir.
Okay. Very nice. As I'm unveiling, I'll make one comment to Dr. Naresh, since you
Yes,
will be
sir.
part
Yes,
of
sir.
the IRAPS group.
Yes, sir.
You can, for this program also, you link with NID, National Institute of Design,
Yes, sir.
get a group of students involved, how to communicate this message into the community. Try to
Yes,
do
sir.
it with innovation.
Yes, sir.
This is the IRAPS program, but will be as part of our collaboration with NID. They'll be very interested in the communication strategies for this.
Yes, sir. Thank you, sir. Very good, sir.
Thank you, sir. Now we'll be starting presentations for the day. I request all the audience to hold the questions for the end of the session. You can also post it on the chat box on Zoom meeting, and our audience from the YouTube live can post it on the comments. I invite Dr. Naresh Kumar, who has a special interest in breast oncology and has taken many initiatives towards breast cancer awareness in various institutes, to present to us a talk on the concept of Breast Cancer Awareness Month.
Thank you, Dr. Pavitra. Good evening once again to all the dignitaries and senior colleagues. Today I'll be talking about the importance of Breast Cancer Awareness Month and the concept of the pink ribbon. Breast Cancer Awareness Month is being celebrated universally as a health campaign every October. It all started in the United States by the American Cancer Society, which had then partnered itself with one of the leading producers of anti-cancer drugs, especially for carcinoma breast, and presently the AstraZeneca. So the purpose was to increase the awareness of breast and breast diseases among women in the US, and to educate people about the importance of early screening and treatment, which sir has already told in length about it, and to promote screening mammogram. And mammogram was a time when mammogram had just come into the market, and they knew that this had a lot of prospects ahead, and it could be the game changer as far as early carcinoma breast was concerned. In addition to creating awareness, they also went ahead to support those who were survivors of carcinoma breast, and to raise funds for research into its cause, prevention, diagnosis, treatment, and cure. And the concept of pink ribbon, it dates back to the story of a Californian lady called Charlotte Haley. And she was the cancer survivor, and her mother also was suffering from carcinoma breast. And at that time, she felt somewhere down around 1980s and 90s, early 90s, she felt that not enough was done towards cancer care in the United States, especially in California. And she wanted to bring it to the knowledge of the legislators that a lot of funding is required as far as comprehensive cancer care towards breast cancer is concerned. And she went about distributing a lot of materials, especially pamphlets and the peach-colored ribbons, to spread the awareness of cancer breast in the city of California. So, but this was the magazine which was closely associated and covering up all the activities of the American Cancer Society, Self magazine. The magazine approached Charlotte Haley to give the copyright for the peach ribbon. However, she refused to do so because she thought this was being a commercial kind of event. So she didn't want to part this peach-colored ribbon. So later on, they decided to go on the pink ribbon, which is they thought is considered as feminine, caring for people, being very good and cooperative. And they made this and used this symbol in the year 1992 to promote breast cancer awareness. And today, universally, this has become the symbol of breast cancer awareness across the world. And in addition to having a lot of activities and spreading awareness of carcinoma breast, there are other activities which happen through in the month of October throughout the world, like Pinkathons, lighting up of the heritage building with pinks. So this has already been spoken about by Sir. I just briefly get into the background of this disease. Breast cancer is a commonly diagnosed cancer in the world. It accounts for 23% of all cancer in the women globally, and it is the second most common cause of death from cancer among women in the world. And this is the statement which Sir has already made. The difference in the 5-year survival between developed and developing countries. In developed countries, as high as about 90%. In developing countries, it is very dismal. It's about less than 40%. And it is also predicted that the global prevalence of breast cancer anyway will cross 2 million by the year 2030. And the majority of contributions would come from developing countries. And as far as Indian statistics and data is concerned, we've got the data released from the ICMR in the year 2020, latest in the month of August, under the aegis of National Cancer Registry Program. And this data was a cumulative data which was taken from the year between 2012 to 2016 from the 28 PBCRs that are registered under the National Cancer Registry Program in India. So we find that there are a lot of data which is coming from the PBCRs, the registries, and we see that the Hyderabad district region tops the list with 48 age-adjusted incident rate of carcinoma breast per lakh population, with Meghalaya on the bottom, about 7 per lakh population. Of course, the figures could be the tip of the iceberg, and still a lot of work and the challenge is there for us to get the data as far as the incidence of carcinoma breast is concerned. And the reasons for dismal figures in India, there are a lot of factors. One, the low level of awareness, as already spoken by Sir, and that's the greatest challenge that we have. We need to make every single woman in this country aware of the breast and breast-related disease, and also the last women in the world, in our country, also must be aware of this particular breast and breast-related diseases. And delay in presentation, maybe because of the fear and the stigma that is associated with the disease. So they present much later in the stage. We have already escalated the stage. So the prognosis, as and when the stage escalates, the prognosis also becomes poor, and the disease-free survival and 5-year survival also goes down. And other factors which contribute to these low figures in India is poor compliance from the patient. There is incomplete treatment regimens, in which case patients drop out of treatment regimens. These are very tightly regulated and tailor-made treatments that are available today for carcinoma breast. And there is limited access to very effective treatment, like dedicated breast centers, what is there in developing countries. Of course, we need to establish and the roadmap for establishing the dedicated breast care unit Sir has already given us, and that is the way forward possibly to increase the awareness and to treat breast cancers more effectively. In developing countries, the survival is much better, already told by Sir, because of the widespread awareness. There is extensive screening mammogram, and there is easy access to very effective treatment in developed countries. So the survival is as close to 90% in developed countries. What has changed in breast cancer over a period of time? There are a lot of things, a sea of change, starting from the understanding of breast carcinogenesis, the tumor biology. There is paradigm shift in both diagnostic as well as therapeutics. There is multidisciplinary, multimodal treatment options that are available, which has improved the survival rates significantly today. And this statement I want to make is the scaling down from the maximum tolerable treatment to minimum effective treatment. So days are gone when we are bombarding the tumor cells with maximum tolerable treatment. And I refer it to the Alsteden era, where there was radical and extended radical mastectomies being done. And today we no longer do that procedures. We have evolved in the understanding of carcinoma breast, and we are doing as little as possible, but again, completely in line with the principles of oncology. So we are advocating breast conservative surgery, especially in early stage tumors, where we are removing the tumor with a good margin, again preserving the form and function of the breast, and that is what we call today as the breast conservative surgeries. And thanks to all the multimodal treatment options that are available today, the hormonal therapy, the chemotherapy, the immunotherapy, and the gene profiling that we do for the tumor, oncotyping, and mama prints that are available today is it's really a world. It's made the job much easier, and target the breast tumor as well. So at this time, I just want to remember a few personalities who made landmark contributions in the management of carcinoma breast. So William Stewart Halsted was an American surgeon. He proposed that breast cancer starts as a local disease and then starts to spread in a very contiguous fashion to the axilla and then becomes a metastatic disease. But, and then that was the understanding at that time. He developed the techniques of radical mastectomies, where the entire breast, the pec major, the pec minor, the entire groups of lymph nodes in the axilla used to be removed just to improve the survival of breast carcinoma patients. And after that came this person. There's again, he did a lot of work in the tumor biology, and also said that breast cancer was not a local disease, it is a systemic disease right from the beginning. And he was one of the founding members of the largest breast project and the bowel project that happens in the US, the National Surgical Adjunct Breast and Bowel Project. And he led the first trial to test the drug tamoxifen. Even today, it's a very good drug as far as it's a selective estrogen receptor modulator, which gained its importance in the year 1992. It is because of this person. And he started advocating that not radical procedure is the answer for carcinoma breast. Less radical procedure is the answer for carcinoma breast. Then came this person, who was an Italian oncologist, Umberto Veronesi, and he was the one who popularized this technique of quadrantectomy. So breast is divided into 4 quadrants. He said a tumor in one of the quadrants, early carcinoma breast, just need to do a quadrantectomy without removing the entire breast. And he led one of the largest trials in breast carcinoma between 1973 to 1980, and it was popularly called as the Millen-1 trial, and where he compared 2 arms, one arm with the radical mastectomy against the quadrantectomy on the other arm. And he made his landmark publication in the year 1981, and he stamped his authority and said that breast conservative surgery will be the standard of care for patients with all early carcinoma breast. Then came this personality, Dr. Armando Gilano, the surgical oncologist in the US, introduced the technique of sentinel lymph node biopsy for breast cancer, and he led these 2 famous trials, Z0010 and 0011, is the ECOSORG group. And he described this technique of sentinel lymph node, where he injected a radio-opaque dye into the tumor, and he wanted to check the first draining group of the axillary lymph node would have any tumor tissue or not. So that was a technique he advocated, and he retrieved the first echelon group of lymph nodes from the axilla to study the morphology and the histopathology of carcinoma breast. And he also proved that axillary lymph node dissection is not necessary as far as if the sentinel lymph node biopsy is turned negative, especially in early carcinoma breast. And that would also, and he did this trial, that Z0010, that compared the 2 arms of axillary lymph node dissection complete, and with sentinel lymph node only. If sentinel lymph nodes were negative, then there is no need to go ahead and do a complete axillary dissection, which would reduce the morbidity of having a axillary lymph node dissection done, like the limb edema, paresthesia, and other. And it did not add any added disease-free survival or overall survival in patients with early carcinoma breast with node negative axilla. So what are the ways forward, especially when we're talking about carcinoma breast early diagnosis? So I would rather put this into 4 P's. First P is to propagate the knowledge about breast and breast diseases to all women in the country, as Sir has already given a clear roadmap as to how we started off this project in Tirupati, one of the projects which has made a huge impact in the screening as well as screening and awareness of breast. So these established and these models which have successfully being done could be the role models for propagating the knowledge of breast and breast diseases. and also implementation research, as sir has already spoken about. The next P is to promote breast self-examination to every woman so that she understands her breast and also knows how a normal breast feels and what is the immediate problems that can be encountered in the breast, and so that there is prompt reporting of breast symptoms to the healthcare provider. And once it is reported, it is the duty of the healthcare facility to screen them and see if there is any issues related to the breast tissue or breast test, and you can treat it accordingly. So the earlier you detect, the better is the prognosis. So the bottom line statement that I want to make today is early detection offers very good prognosis. So that is what we will be trying to achieve in the years to come, to spread the awareness of breast cancer and breast self-examination. That will do a world of good for our patients, and also to improve the survival in our country and other developing countries. Thanks for the opportunity, and Jai Hind.
Thank you, sir, for the interesting talk on the concept of pink ribbon, which has now become synonymous with breast cancer awareness and the journey of breast cancer treatment. Now I invite Dr. Hemant Kumar Singh. He is an assistant professor in Department of General Surgery. He is trained in surgical oncology from Tata Memorial Hospital, Mumbai. I request him to speak on breast cancer screening, when to do it, and in whom to do it.
Thank you, Pavitra, for the kind words. A warm good evening to all. I would like to share my screen. Okay, starting it straight away, Pavitra. At the end of this webinar, all will be able to understand the importance of breast cancer screening, and we will be able to advise women for cancer screening. Also, remove the fear from the minds of women about cancer, and when to refer the patient to the appropriate care or the specialist cancer care. As sir has already told that breast cancer is the leading cancer amongst women, which is clearly seen in this map. It's the leading cancer in 154 countries across the globe. Similarly, seeing the mortality, breast cancer leads the mortality in more than 100 countries across the world. Now, coming to the status of India, as sir has already told that we almost 50% of the breast cancer presents in a locally advanced state. Also, breast cancer is the leading cancer in India as well. Also, there's a significant increase in the incidence rate of breast cancers across all the PBCRs over years, and the incidence is gradually rising. And in 1 in 29 females would have a lifetime risk of developing breast cancer. Now, as cancers are becoming more and more common, but we are lucky that the leading cancer like breast cancer and cancer cervix can be screened. Let us see how. So Robbins told that the only way to escape cancer is not to be born. So since we are already born, we all have the risk. So let us see with our knowledge and understanding what best can be done. So what are the tools we have? One is breast self-examination. The other is clinical examination, X-ray mammogram, MR mammogram, PET-CT, and scintigraphy. These are the various investigations and examinations which are available, among which the last two, the PET-CT and scintigraphy, are not used because there's no enough evidence to support it. So clinical breast examination is done by healthcare professional when the patient presents to the outpatient department, and breast self-examination is done by the person himself at home, and this will be spoken in detail by Dr. Pavitra. And ultrasound breast is one of the adjuvant investigations which is done with the X-ray mammogram. lesion if it is seen on X-ray mammogram. And the role of MRI breast is seen in high-risk women. Now, what are the types of screening which is available with us? One is the average risk screening and the other is high risk screening. Now, who belong to this average risk group? These are the people who do not have any risk factors. And what risk factors are we talking about? We are talking about a personal history of breast cancer, or if you have a known family mutations like BRCA1 and BRCA2, or you have received radiation, say for Hodgkin's lymphoma, in the age group of 10 to 30 years. So all this will fall under high risk category. If you don't have all this, you will fall under average risk category, because the screening type, timing and all are different in both these groups. X-ray mammogram. So if we are screening those asymptomatic individuals who do not have cancer, so we have to choose a group, I mean a age group in which the incidence is very, very high. So that age group is 40 to 70 years of age. So we usually do not screen women who are less than 40 years of age because of the lower incidence of cancer. The second thing is that there are large proportion of their breast is extremely dense, which can obscure the isodense lesions. Also, younger the women, if they have cancers, they are fast and aggressive, which are called as interval cancers. So screening in less than 40 is not that helpful because you're not targeting the target population. So NCCN has given the way forward, saying that at the age of 40, and annual screening mammogram is to be done for all. It leads to greatest mortality reduction, as well as more life saved and also more life years gained. The people is the survivors are going to live for a longer period of time. Now, while some societies, the exact cutoff at when to start screening is not very clear. Some say 50, some say 45, but it is told that the woman at 40 qualifies for screening. So at 40, you can very well discuss with the patient and start off the screening right from 40 years of age. Now, what are the advantages of having an X-ray mammogram? You can detect smaller tumors and you need less aggressive treatment regimens, more treatment options in terms of surgery, breast conservation, and more cures, and most importantly, increased survival. Harms of X-ray mammogram. Now, since you are doing imaging, you are likely to pick up some benign masses, and 80% of breast masses are benign. So the chances of overdiagnosis, false positive, can cause undue anxiety in women. And some studies have also told that if 500 or more false positives may be seen per life we are trying to save, so the cost benefit ratio is good still in, so uh, the benefit is outweighing the risk. Now, clinically diagnosed cancers are larger in size, less treatment options. We definitely need more chemotherapy, more radiotherapy, more extensive surgery, more cost, and at the end of it, we have less survival. I mean, you do all this and still you don't see them live for long. Now, does it mean that if the mammogram is normal, all is well? No, because some of the cancers cannot be diagnosed by mammogram alone. You need clinical examination. That is for some cancers like the Paget's disease or lobular carcinoma in situ. So, you always have to have a clinical examination which is followed by a screening mammogram. Also, whenever you are referring a patient for mammogram, please counsel the women of the benefits, of the risk, and also limitations of mammogram, that we may not be able to detect always the tumor. Now, as I told you all, that the benefit of X-ray mammogram, it definitely outweighs the risk. And there have been studies between annual mammogram or like mammogram done once in 2 years. So so the annual mammogram is shown to be better in terms of survival, because mammogram can detect a lesion interval cancers are low because the duration is only 1 year. But most important is that the woman should be compliant. It's not that you do for 2 sessions and for the next 2 years there is no, I mean, the patient that does not come for a mammogram. Now there is one more scenario. Should we screen the elderly? Is there an upper limit for screening? So the answer is there is no upper limit for screening as long as the woman remains in good health, and it's a clinical call that the life expectancy more than 10 years, you can very well screen the woman for cancer, and the screening guidelines are all the same as I've told you. Now let us apply this in the clinic. Now you have a patient who is a retired government clerk. She's 72 years old and is a case of COPD, congestive cardiac failure, coronary artery disease, and is having general poor health. Now she's bedridden, performance status of 3 and 4. Now, would you like to screen her? Now, if you look at the data given here, it looks that she would not be fit for any form of treatment, whether it is surgery, chemotherapy, or radiotherapy. So, would you like to screen her? So, the answer would be definitely not, because there's no point in screening if you are not going to treat her. So, now the next is that what is the role of MRI mammogram? This is usually not used routinely, but it is used in those women who are having high risk mutation like the BRCA mutation, or you have an untested relative of a mutation carrier, or there are certain models. Based on those models, if the incidence of breast cancer is going to be more than 20 to 25% lifetime risk, then you would advise a MR mammogram. We would see how we can use this. Let us see. Now, as I told you all that high risk screening is like is done in case of prior CA breast, or if there is history of thoracic RT, or if there's a genetic predisposition, or if there is a history of a pre-malignant lesion like lobular carcinoma in situ, or atypical lobular hyperplasia, which confers more than to 20% lifetime risk of breast cancer. So these are the only 6 indications which fall under high risk screening. All the others would fall under average risk screening. Now let us see how we can apply this. Now if a lady who is 25 to 40 years old walks into the clinic saying that she heard on the TV that breast cancer is increasing, and on history that she does not have any family history, there is no other high risk predisposing factors, there is no BRCA mutation, so you would classify her as high risk. Now what is the answer for this? You are going to examine her clinically and ask her that she needs to get her examined 1 to 3 years, and you teach her breast self examination. That would suffice for this lady. Now if the lady's age is more than 40 years, same scenario, but the age is more than 40 years, 40 years, asymptomatic, average risk, so not having any of those high risk features, then again you do like you do an annual screening mammogram coupled with annual clinical examination, and teach her breast self examination so that she can be aware of her breast and any changes that will happen. Now one more very important aspect is genetic screening. What are the indications that you would screen a patient for a mutation which would have caused the cancer? Now by far, if the cancer is occurring very early in life, say less than 50 years of age, you have a cancer diagnosis, you would do a genetic testing. If you have a triple negative breast cancer diagnosed less than 60 years, you do a genetic testing. If you have 2 breast primaries, say you are having a bilateral breast cancer, or you're having 2 different histologies in the same breast suggestive of 2 breast primaries, you do a genetic screening. Also, 2 most important indications which are far more common is that if the patient is having breast cancer and yet another relative with a breast cancer or a ovarian cancer or a pancreatic cancer or a prostate cancer also fits to be screened genetically. That means we are going to screen the patient for BRCA mutation, which is the most common cause of hereditary breast cancer ovarian syndrome. Now, let us see how we can apply this. Now, if you have a 25-year-old lady who walks into the clinic with the concern that her mother had breast cancer and she was a diagnosed case of BRCA positive, now she's worried that she may also get breast cancer. Now, what to do for this scenario? Now, the first thing you have to understand that BRCA, once you have diagnosed that her mother had BRCA mutation, then it's a very big thing. That means to tell she definitely needs genetic counseling because the implications are huge. Implications are huge in the sense that she's at risk for multiple tumors. Say it starts from breast cancer, ovarian cancer, and many other tumors which are likely to happen in her lifetime. Also, she is going to 50, and also she is going to transmit this to 50% of her children. So this is a very important social and psychological impact. So they need a detailed genetic counseling, which is very, very important. And she has to be understood that what is the need to do this test. Okay. And in these people, we start screening at a very younger age. She is now 25. We can ask her to start getting annual X-ray mammogram from when she attains 30 years of age, or 10 years prior to the youngest history of breast cancer what we can collect from her history. Also, X-ray and MR mammogram need to be done at every 6-month interval for these patients so that we do not miss out any interval cancers because these genetic mutations are fast growing tumors because BRCA1 is a tumor suppressor gene. So mutation in this can lead to fast growing cancers. And educate her about breast self examination. And one more most important thing, that you can counsel them for some risk reduction surgeries which can be done so that the breast cancer can be completely prevented. So those are risk reducing mastectomies and risk reducing salpingoophorectomy once they have completed their families. Now, coming to the fact that there are multiple risk factors for breast cancer, let us see what all can be changed in this. Menarche, menopause, nulliparity, proliferative breast disease, none of these can be changed. Only two things can be changed are alcohol use, postmenopausal obesity, and maybe this age older than 35 years for the first childbirth. So probably these can be changed. And so we have to adopt the healthy lifestyle and limit alcohol consumption, do vigorous physical activity. More so if when the lady becomes postmenopausal, she needs to at least 150 minutes of moderate intensity aerobic exercise for the entire week. For the entire week, it needs to be 150 minutes. So avoid abnormal weight gain, and also please breastfeed. I mean, this they should have done it earlier, but breastfeeding also decreases the chances of having a breast cancer. Now, take home message is that please get your near and dear ones screened. Start at home. Mothers, sisters, get them for screening such cervical and breast cancer, which can easily be screened, and later we can go from friends, relatives to the community. Now, this is one, I mean, she needs no introduction. She was BRCA1 positive and she underwent bilateral mastectomy followed by breast reconstruction. So the options are still there. If you can diagnose them well in advance that they have a genetic mutation, you can still make their life beautiful. She is yet another award-winning American musician, Sheryl Crow, and an inspiring advocate for women health, and she has been all proactive about annual mammograms and teaching women about breast cancer screening. Similarly, she's Christina, even she was also BRCA positive, and she's an American comedy actress. She also underwent bilateral mastectomy after finding out that she had carried the BRCA gene. Thank you all for your kind listening. Now I would like to call upon Dr. Pavitra, who is my colleague. She is a young and dynamic surgeon, and she has completed her post-graduation from AIIMS, New Delhi. She has taken active initiative to create awareness about the breast cancer amongst the general public.
Thank you, Hemant, for the kind words. Now we'll be talking about breast self-examination and the danger signs of breast cancer. This has been extensively dealt already about the global impact and the impact in India on breast cancer. I just want to highlight it once more, just so that the breast self-examination which we are talking about, in the West, it has been, many studies have come out which says that it does not improve the survival. But the scenario is not same in India, and we do not have any studies in India to correlate the breast self-examination practice with the survival of breast cancer patients. So like we have already spoken that it's the most common cancer and it has surpassed the cervical cancer. And the 5-year survival rate of these breast cancer patients is a dismal 60% compared to the 90% in United States. And we already know the reason for this. It's that at these diagnosis, the stage at diagnosis is locally advanced breast cancer, which is our stage 3. 57% of the women present at stage 3. Locally advanced breast cancer includes a lump which is more than 5 centimeters. So a woman stays with that lump until it's more than 5 centimeters. And it can have involvement of skin, overlying skin, or the underlying chest wall, and there is involvement of the local lymph nodes also. Whereas in US, the average size of the lump at presentation is 1.8 centimeters. So logically, if we think, we know that a 1.8 centimeter lump, to pick it up on a breast self-examination is much more difficult compared to a more than 5 centimeter lump. So with breast self-examination, definitely in the Indian population, they will benefit if they inculcate the breast self-examination. And not just that, the another important thing, other than the later stage, for a country like India, which is a developing country, and more than 70% of the population stay in the rural region, where the health infrastructure is limited, and even for the curative management, the infrastructure is limited. So a preventive measure like a screening mammogram, which can be applied universally, is easier said than done in a situation like in India. In that places, if we can inculcate the breast self-examination, it can help detect the breast cancer early, because it's a simple, quick and cost-free. All it needs is the awareness and education of the women, and it will also increase the awareness of breast cancer. The women will be aware about the signs and symptoms of breast cancer, so they can report to the doctor earlier. So let's talk about the danger signs of breast cancer. All these danger signs can be picked up on breast self-examination. The signs most commonly seen is the lump in the breast and axilla. The lump in the breast and axilla can also lead to asymmetry of the breast compared to the other size in size and shape. These skin changes are usually seen in the advanced malignancies where the skin is involved. You can see that the skin can be thickened over the lump, localized thickening of the skin in the breast compared to the rest of the breast and the opposite side. And you can see a picture over here which depicts the puckering of skin, which is again stage 4A, involvement of the skin. And you can see the pudy orange over here, which is the orange peel appearance. It's caused by the blockage of dermal lymphatics because of the malignant cells. And in the same picture, you can also see the ulceration. Ulceration means the skin has been invaded by the malignancy. And redness or rash can be seen in inflammatory breast cancer, which again falls under T4. And the other signs which we can see other than the breast and the skin over the breast is the changes in the nipple. Recent onset nipple inversion is suggestive of a central quadrant mass. There can be nipple discharge, which can vary from serous to sanguineous to frankly blood discharge also. And last but not the least is the Paget disease, where the malignancy involves only the nipple. You can see in this picture, They usually start off with scaling of the nipple and rash of the nipple, and ultimately it can lead to ulceration and complete destruction of the nipple areola complex. So I now want to quickly guide you all through the steps of breast self-examination so that we can educate the women around us, the patients we visit, who visit us, and when we go into the auxiliary healthcare workers, the ASHA workers, who in turn can train the women, we can accelerate the detection of breast cancer and thereby the decreasing downstaging the breast cancer stage at presentation. So the breast self-examination follows the same tenets of clinical breast examination, which means we do the inspection first and then the palpation. These steps are simplified so that a general public, a laywoman, can understand how to do it and what to notice in it and when to report it. Okay. Now we ask the patient to stand in front of the mirror, and she has to strip up to the umbilicus so that she can see both the breasts. And whenever we are doing a breast examination, even clinical examination, we compare one breast with the other breast. Usually the one breast is affected, which will lead to an asymmetry between the breasts and which can lead to early pickup of the signs. So we ask them to stand in front of the mirror, place the hands on the waist so that the entire breast can be visible, and compare both the breasts. They need to look at any change in size and shape, which both are asymmetry of one breast compared to the other side. Sometimes superficial lumps can be seen on inspection itself. Now we will be looking at the skin changes, which we have spoken already about. A localized thickening of the skin over the lump compared to the other places. Orange peel appearance, which is a pure orange sign. Redness or rash can be seen in inflammatory breast cancer. And dimpling or puckering of the skin when there is involvement of the skin overlying the lump. Then we need to ask them to inspect both the nipples, look for any rash or scaliness on the nipple, or a recent onset nipple inversion. Many women have a congenital from birth or from puberty nipple inversion, which is not suggestive of malignancy. A recent onset nipple inversion is significant. When they're checking the nipples, we need to ask them to check for the nipple discharge. Again, the nipple discharge nature may vary from serous to frankly blood. In the inspection, when they are standing in front of the mirror with hands on the waist, they can't see under surface of the breast. So we ask them to raise both the hands so that the undersurface of the breast is visible, and the same signs, the asymmetry and the changes in the skin, has to be looked for on the undersurface of the breast after raising the hands. And now we'll go to the palpation. So we need to teach the patients exactly how to do a palpation. Lying down leads to a better detection of lumps because the breast distributes uniformly on lying down. So we should ask them to lie down and feel the breast. And they should use the opposite hand to feel the breast. And the most important thing over here is the breast has to be felt by the palmar surface of the fingers. Usually the patients use thumb to palpate the breast between their thumb and fingers, which will lead to lumpiness in every woman. So we need to instruct them to use the palmar surface of their fingers to palpate the breast. And another important thing here is, as you can see in this picture, they need to follow a particular pattern. It can be radially from outside inwards, or from one side of the breast, one quadrant towards the nipple, each quadrant towards the nipple, or it can be vertically from one side of the breast to the other. The whole concept of this is so that the patient does not miss any particular part of the breast during examination. So if she follows a pattern every month, the likeliness of missing a part, a lump somewhere, is very less. And other than that, we need to instruct them to examine both their axillas at the end of breast examination. And we repeat the same step on standing up. Sometimes some lumps in certain quadrants can be felt better on standing up than lying down. And this, if done in a shower, it facilitates the examination because the skin will be wet and slippery. They can use some lather also if there is some tenderness to palpate the breast. Same procedure, both the breast have to be checked and both the axilla needs to be checked. And the most important thing we need to educate the patient is all these signs I have told till now is seen in breast cancer, but it's not indicative. It's not diagnostic of breast cancer. So we need to educate the patient that there's no need to panic if they find any of the signs. The only thing that has to be done is to get it evaluated. Evaluation, only by evaluation, anybody can rule out the malignancy or confirm the malignancy. So we do what is called as triple assessment for any breast lump, which includes the clinical breast examination, imaging. It can be either an ultrasonography or a mammography based on the age of the patient. And based on the reports of these imaging, a biopsy might be required based on the findings on this imaging. With all these triple assessment, with 99% accuracy, we can rule out or we can confirm the malignancy. And another important thing is this breast self-examination has to be done every month. There are few objectives we get by doing it every month. One of it is they'll not miss it. They'll know it has to be done every month. And another important thing is a female will learn will get to know the nature of the breast, how a normal breast looks, how does it feel. Where in benign breast diseases, if she has been diagnosed with fibroadenosis or something like that, she knows where that fibroadenosis is, how does it feel. Even if there is a small change in that lump or there is a new lump, she'll be able to detect it quickly because she is aware of the nature of how her breast feels. And another important thing is when should they do this examination? It has to be done a few days after the end of menstrual cycles. After menstruation, during menstruation, most of the women get some mastalgia. There might be some changes in the breast which can feel like lumpiness. So some 3 to 4 days after the menstruation and before the ovulation day. Even ovulation day will lead to breast tenderness. The breast examination has to be done during that time. Women who are postmenopausal, hysterectomized, or have irregular cycles can assign a particular date in a month, say 5th of a month or 10th of a month, so that they can do the regular examination. But examination every month is very important so that a female is aware of her breasts. And like all the speakers who have spoken today, from our director sir to our president sir, have been emphasizing early detection offers better survival. Early detection, the lack of early detection is the reason behind the dismal survival in India. So we need to educate the women, use all the modalities, tools we have for the early detection, and breast self-examination is one of the simplest of them, which we can just teach any women we meet, be it patients or our household people or our friends, which will help save lives. Thank you. Now the session is open for question and answers. It can be directed towards all the 3 speakers. Arvind, if we have got some questions from the YouTube live or the chat box, you can just read it out.
In the chat box, there are some questions. Pavitra.
1 second. Chat box there. Yeah. Yeah, I think this is to Hemant. It's about screening mammogram. Dr. Jyoti Kulkarni, she's asking, are there any side effects due to radiations of repeated mammogram like thyroid malignancies?
It has not been reported actually, but I found one statement in the literature saying that for every 1,000, for it is estimated. So for 1,000 women screened from 40 to 80 years, one woman would get a radiation-induced cancer, probably. So this is the estimate, but really I've not found any literature on this. This is one of the lines which I read. So like probably it would mean that 1,000 women into 40. So probably if you do 40,000 screening mammogram in one lady, you would get probably a cancer. That is how I infer this. So it is very, very less. And so that is why it has not been, I mean, there's no contraindication. I mean, people really don't counsel women because the benefit of doing a screening mammogram is much more than a small percentage of side effect which can happen because of that.
May I add one answer to this?
Yes,
May
sir.
I add,
Yes, yes, sir.
even in that kind of a simulation, that exercise of estimations,
Yes,
it is shown that nobody will die of the radiation-induced breast cancer. Even if you cause that hypothetical 1 in 40,000 getting a breast cancer, that cancer will be detected in an earlier stage, so they'll have a 90% cure rate. So it is
yes.
almost dying from a radiation-induced breast cancer as a result of repeat mammogram. It is only a fiction, not a fact.
Yes, yes. Thank you.
And few more questions to Dr. Hemant from Dr. T. Santosh. He asks, what is your opinion about role of FNAC compared to mammography as a part of breast cancer screening? And he also wants to know the diagnostic accuracy of each of these measures in screening patients.
Regarding the first question, like as we are talking about breast cancer screening, so this is the patient that you are planning to screen. So always first non-invasive modalities first. So if you would say that you do a FNAC for any lesion which would be seen in your breast, which is so it would not attract many women. So on the contrary, if you tell someone that you do X-ray mammogram, and in case you find any suspicious thing, then only a needle test would be indicated. So a probably a needle test could inflict some fear in the minds of people, and probably that is one of the reason that in spite of FNAC being very, very accurate, it is not used in breast cancer screening. And the next
Add
question,
something.
yes sir, yes sir.
As far as FNAC is concerned, again, when we talk about carcinoma breast, it is about the core cut biopsy that we are talking today. So it is the FNAC and core cut definitely today biopsy outweighs the FNAC. And as far as carcinoma breast is concerned, core biopsy is the answer today. I just added this to your.
Yes sir. And the next question, the diagnostic accuracy of each method. So the clinical examination is having a sensitivity of probably around 50% and the specificity of around 94. But the thing is that the specificity is so low that you would miss majority of the tumors. So that is out. The next one is you have got the X-ray mammogram, and the accuracies and the sensitivity is around 85% and the specificity is around 90% for this. And MR mammogram is yet another modality which we use, which is having a sensitivity of nearly 100%, but the specificity is very low. It's around 50 to 60 it is 50 to 60%. So you would end up doing more falsely biopsies, and the false positive rates are pretty high in this. And there's no difference in the women who are done by MR mammogram to X-ray mammogram. There's no difference in survival. So a cheaper method would be a better one, I guess. And the major drawback of this MR mammogram is that these specificity is very, very low, leading to falsely positive, more biopsies which rather turn out to be benign benign breast lesions.
Thank you, Hemant. And the next question is about BRCA genetic screening in the Indian scenario. What is the availability and what is the limitations of it?
Now the thing is that if you have to get tested for a BRCA 1 and 2, it would charge you around probably around 10 to 15,000 in the Indian scenario, or in some sectors it will also cost you around 20 25 depending on the hospitals. So it's a big money actually, because the entire surgery for breast cancer gets over in 4,000 rupees. So if you counsel the woman that probably you may have a genetic risk, but if the moment you tell them that the cost, so they become okay, scanner take time to think and they never come back to you. And without a BRCA mutation, I mean, without testing for mutation, I don't know how best we would be able to diagnose. We can clinically diagnose that the patient is having a strong family history of breast cancer, but we really would not be able to diagnose them as BRCA positive without testing for the mutations. And unless we diagnose them with BRCA positive, we would not be able to advise them with any risk reducing surgeries like mastectomy or salpingoophorectomies.
Okay, Hemant, and there's another question related to BRCA gene itself. Dr. Pratyusha Gane asks, how do you screen a lady with strong family history of breast cancer, but the patient herself is BRCA negative?
Okay, so in this woman, if her parents are not positive, I mean, if she's having a strong family history, and if priorly they have not been tested, so and if they turn out to be this gene negative, so you run the entire panel of gene test. So in spite of this, if all the entire panel of gene test also is not there, so it is some mutation which has not been detected priorly. So we need to still treat these patients based on strong family history, and then taking these patients and explaining them in detail about the nature of treatment would be available to them, about the risk reducing surgeries which are available to them.
Okay. And one more question about the screening itself. Sushil Kumar sir asks, what is the role of ultrasonography in screening as compared to X-ray mammogram?
Yes, sir. Sir, one of the things I would like to tell that ultrasound, any calcifications or like any air are the two enemies of ultrasound. That means to tell that a ultrasound would not pick up microcalcifications which are there in the breast. And ductal carcinoma in situ and invasive carcinoma, invasive infiltrating ductal cell carcinoma, are around 70 to 80% of the time will have microcalcification or suspicious calcification. So if a breast ultrasound is not able to detect this, so it would not be wise to do this. But if on X-ray mammogram you get a suspicious lesion which are not able to characterize it, then we would do a breast ultrasound to find out the nature of the lesion. So it is an adjuvant. So we really don't use it for screening because of the thing that it won't be able to detect microcalcifications.
Okay. Thank you, Hemant. The next question is directed to me. Santu Komakula asks, what is the age at which women should start breast self-examination? The women should start breast self-examination at around the age of 25 years and continue it every month.
I think we have taken all the questions.
There's one more question, sir, from Dr. Rajiv.
So I think he has asked.
Yes, Rajiv sir is asking amongst the risk factors which is there for development of breast cancer, the total number of previous biopsies has been included as a risk factor. He asks why is it included as a algorithm in the risk factors?
Yeah, it has been proven that the more number of benign breast lesion, I mean benign breast biopsy, no, it's not benign. It's actually the number of biopsies which have been done is also included in the risk factor because on observation studies it has been found that something like breast density and the number of time the lady undergoes a breast breast biopsy, so they have higher incidence of cancers being diagnosed compared to the others who have not undergone. So there's no real catch in this, but it has been shown in some observation studies, and hence it has been included in one of the most important model, which we call it as the modified Gale model, and is one of the very important things which has been included and is helpful in calculating the 5-year incidence of breast cancer in these women. It's just an observation, sir. I really don't know why, but it has been seen like that.
I thank all the audience for the enthusiastic participation. Now I request Dr. Naresh Kumar to unveil the activities done by Department of General Surgery towards breast cancer awareness in this academic year, including the activities done in this breast cancer awareness month of October 2020. I also request him to present the prizes for e-poster competition which was conducted this month and present the best stories, poems and artwork we have received.
Thank you, Dr. Pavitra. Can you see my screen, Dr. Pavitra?
Yes, sir.
Yes, sir.
I'll just run through the list of activities that we have undertaken during this year as well as during this month of Breast Cancer Awareness Month in the run-up to this event. So it started off with the breast screening camp that was done in our PHC at Muttaki on the eve of our Institute Day. Dr. Hemant screened a lot of patients in the PHC and also spread the message of self-examination of breast and breast cancer awareness, and screened also the ASHA workers at our PHC on the eve of our Institute Day. And it was followed up by our nursing officers who had presented a model of breast self-examination on the Institute Day, and they won the first prize in their category for the poster. And this is the poster of the breast self-examination model that won the first prize. And also our children also took part actively on the Institute Day for the poster competition. That was also on the concept of breast cancer screening awareness, and our students won the second prize under medical students category. And then it was followed up by a health talk. It was a roundtable talk in association with the Press Bureau of India on the eve of the International Women's Day, where we had spoken about again breast cancer awareness and the message that was clear, and we had spoken on this breast cancer awareness. So, same thing. And in this month of October 2020, we had a series of activities. We started off with breast cancer awareness program and also the self-breast examination for our patients in our OPD at AIIMS Mangalagiri for our patients. And it was also followed by the same event for our housekeeping staff and data entry operators and the female staff of our institute in the OPD AIIMS Mangalagiri. Then this activity was also undertaken, and a special thanks to Dr. Kirti Bolineni, who is our internal complaints committee member, and she is also the president of one of the regional Mahila Mandals in Krishna district. So when I spoke to her, she immediately responded very quickly, and she also gave us this opportunity to spread the message of breast cancer awareness and also breast self-examination among their Mahila help groups on 4 different days. In the afternoon, we had conducted this webinar, and around more than 100 participants joined us on the webinar, and it was useful to them. So these are the event photographs of those breast cancer awareness, which was done through the Zoom. And there was enormous questions also after a lot of people had a lot of queries, which were clearly discussed, and Dr. Pavitra had spoken at length about all these and answered all those queries. And we also conducted this e-poster, and we had received about 20 posters across the country, and and in that we had to judge the best 3, and these 3 would go into our upcoming issue of our e-magazine. The first prize was backed by Ms. Kirti, nursing officer from AIIMS Bhubaneswar. The second poster to Dev Jyoti Biswas, who is a lecturer at Pragati College of Nursing, Bengaluru. And the third prize was backed by Betsy K. James, assistant professor, Bishop Benazir College of Nursing, Kerala. And we also received certain interesting poems and artwork. And one of our students wrote that she got the first prize at the artwork. R. Mani Varshini, who is our own student, AIIMS Mangalagiri, for her artwork on breast cancer awareness month. And the second prize was backed by Monica Ballam, who is a nursing student at NRI College of Nursing, Mangalagiri. And a few patients also shared their success stories or cancer survivors. And one patient was from Visakhapatnam. She had a she had shared her story of carcinoma breast, how she got diagnosed, how she went for early screening, and how successfully she fought this cancer. And so this was an interesting story of a 28-year-old Visakhapatnam lady. And that is our team. Thanks to the entire team who have done a very good, and they've been running from pillar to post to get this program on board and make it a grand event today. Thank you.
Sir, there's one more question from Mange Karsi madam. She asked, what are the present available cancer services programs at AIIMS Mangalgiri?
What are the present
programs, services programs we have at AIIMS Mangalgiri?
So right now we are having our OPDs. We will be taking all the, we are screening all the patients for breast cancer, and also we are getting patients from gynecology department for even cervical cancer. And Dr. Hemant, who's an oncosurgeon, who's there on the board with us. So we are doing the initial, since we have not opened up our other facilities like the operating rooms and radiotherapy units and chemotherapy units. At present, we are just doing the screening for breast cancer, cervical cancer. I hope I've answered that question.
Thank you, sir. Now I kindly request you to deliver the oath of thanks for the evening.
Can you hear me?
Yes, sir.
It was a wonderful talk by all the speakers. And first, I would like to thank our President, sir, for having accepted our invitation to join on this platform today. Sir has given a lot of inputs about his experiences, and the data that he has given us really has put the things on board in the right direction. And also words of encouragement. Sir, you have set the ball rolling, sir. And the concept model that you had shared with us, the pink bus, has made a huge impact in the society, especially in Andhra Pradesh. So these successful models can be taken forward, and the legacy would continue. And I thank our director, sir, who has been very supportive and guiding from the front. And I thank our Deputy Director, Administration, Mr. Shamdeep, for having coordinated this event with our President, sir. And I thank our Dean, Medical Superintendent, Associate Deans for all their support. And also thank all the senior faculty members, colleagues, nursing staff, and the IT department who's been supporting us from the back end. And also thank our dear students who have been actively participating in this. And though we couldn't see them on Zoom, they are live on the YouTube channel. And I thank them for their active participation. And last but not the least, it's the entire team of surgery, Dr. Hemant, Dr. Pavitra, nursing colleagues, Arvind and Harshdeep, and the support team of surgery department who have put in a lot of efforts to make this program a grand event today. I once again thank all of you for having given us an opportunity, and also participated in large numbers. And once again, thank you all. If I've left out somebody's name, it is purely unintentional. Thank you. Sir wants to add something. Sir, please, sir.
I just want to convey my privilege and pleasure to be part of this hour and a half. I just want to give a parting message that all these timelines, like Awareness Month, one is to bring focus to the problem. And also, it then gives us a perspective on what we have to do. So taking this Breast Cancer Awareness Month example, let us now join, you have taken the lead and doing this, Dr. Naresh.
Yes,
and now it is time to develop a multidisciplinary, multifaceted approach across departments and across institutions to articulate some priorities between this October and next October. What should be our thing we want to come and present next year? And that will drive the process. And in order to drive the process, then you can put the people in place. So I would like to encourage you to keep the momentum. and use this as a starting point. And while we don't have a full-fledged inpatient facility, we need to be geared up to doing some of the procedures in alternative setting, or be ready to do this, and try to do and also very important, you mentioned in one of the things is compliance. We cannot say that anymore in terms of patients are not compliant. I do not like that kind of a phrase, the patient, because I have a lot of examples, and I'm using that into patient safety and public safety. So that is one thing we can work with other institutions in terms of what I call vertical equity. We call it equity of care. We only focus on horizontal equity. You will say, oh yeah, we have the radiation, we have medicine, we have surgery, we have screening. The patient did not comply. We have to look beyond it. Why is the patient not compliant? It is not that lady who's going to ignore her breast cancer. There are other competing things in her family. If she has to come every day for radiation, or if she has to come for chemotherapy, the husband and the family and all this, she cannot put and stand still and come here. So that is called vertical equity. So let us look at it as a fundamental principle of equity, going beyond horizontal equity. Horizontal equity means every individual will be able to have the care available to him or her when in need. Having made that available for a given patient, for their ability to avail that care is differential. I give you an example of a breast cancer woman. How she can come from community to have a screening. You have a screening facility in the mammogram. You will say the patients are not compliant. We need to understand the reasons behind the compliance, and we need to cater towards the people-centric fashion. So let us look at it as a very, very important thing for the next 5 years. How does the vertical equity play into the breast cancer cure rate in India? That is very important. Very, 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 very important. As one important thing you can do is to how to do in women's health, how you bridge this vertical equity. Let us work on that in a big way. And that is going to drive what we can achieve. So let us then start thinking about simple projects, complex projects, and projects that are 1 year in duration, project that will be 5 to 10 year duration. Okay, and involve all of them beyond your departments to be co-equals in participating in this big effort. So congratulations on an excellent hour and a half, and I will be very interested because of my personal passion for this women's health, and in which cervix and breast key roles, and other oral cancer also is very important. Thank you.
Thank you very much, sir. It's a pleasure having you, sir. So can we end the meeting, sir?
Director can.
Director, sir, can we end the meeting, sir? I think we'll end, sir.
Okay, thank you. I will take off now. Thanks a lot.
Thank you, sir. Thank you, sir. Thank you very much, sir.
Thank you, sir.